Here we have a case of a male and 22 years old, underwent recently laparoscopic cholecystectomy, and he is post-lab coli, patient deteriorated with shortness of breathing. His chest X-ray shows diffuse alveolar opacities. He underwent HRCT. This is the appearance. Diffuse consolidation and ground glass opacity. Also, you can see here the crazy paving, the interlobular septal thickening with secondary pulmonary lobule ground glass opacities, giving the appearance of crazy paving. As you can see here, ground glass opacities with interlobular septal thickening and intralobular septal thickening. These are the intralobular lines thickened and the interlobular septal thickening as well, bounding the secondary pulmonary lobules. As a complication post-surgery, we have ARDS versus pulmonary edema. Pulmonary edema occurs in such cases due to negative pressure, due to forced inspiratory effort against laryngeal spasm, causing this development of pulmonary edema. We can differentiate from radiological point of view between ARDS and pulmonary edema by presence of the significant interlobular septal thickening. Here are the interlobular septa. Here, patient couldn't hold his breath. That's why there is respiratory motion artifact, but still we can see the interlobular septal thickening significant in amount. Here you can see it nicely, drawing the secondary pulmonary lobules. Here the coronal scan as well, see. Always I prefer to evaluate the interlobular septal thickening in the anterior aspect of the lung in the coronal, where it shows nicely the hexagonal appearance of the secondary pulmonary lobules. Again, you can see also the crazy paving here in the right upper lobe. In the left lobe, you can see also the interlobular septal thickening. They are significant in amount associated with the alveolar ground glass and consolidation. Plus the presence of pleural effusion. All these are in favor of pulmonary edema over the ARDS. Here, I share this slide to talk about how to differentiate. The interlobular septal thickness is common in pulmonary edema, but not in ARDS. Pleural effusion, not typical in ARDS, but it is often present in congestive heart failure or any pulmonary edema. The ARDS not associated with cardiomegaly. This in case of congestive heart failure in general, but in our case in particular, we don't look for the heart size because he is a young guy, normal cardiac size. Already we have the reason, which is post-surgery. So we rely on the interlobular septal thickening. We rely on presence of the pleural effusion. Generally speaking, pulmonary edema starts centrally. If you have serial X-rays, you will notice that in pulmonary edema, it will start centrally, then proceed or extend peripherally. But in ARDS, it's starting from the start as a uniform distribution of the alveolar or by peripheral distribution. For the resolution of survivals from ARDS, which is a lethal disease, it is slowly resolving, and percentage of the patient will leave pulmonary fibrosis changes. But in pulmonary edema, once resolved, they don't leave lung scarring or any parenchymal changes behind. Lastly, both can coexist as an underlying process in the lung, ARDS and pulmonary edema together, but this can be detected by pathology, histopathology, not by radiology tools.